75% of water and 25% of solid matters, which compose of dead bacteria, of indigestible food matter, of cholesterol and other fats, and inorganic substances and protein. So what normally passes in the stool is cell debris, the bile pigments, and the dead leukocytes. And the odor of the stool, the specific odor of the stool, is caused by chemicals that is like the indole, skatol, or hydrogen sulfide that make it or give it the special odor. Now, the normal frequency and consistency of bowel motion movements varies with child age and diet. So there is an exact number of the bowel motion for each child, for each different group of age. So, but the normal frequency in young infants, it may be 3 to 10 stools. So sometimes you may find in a practice, the mother say, my baby, my infant has 6 stools, 7 stools per day, and be normal, especially if the baby is with breastfeeding. So, while the older infants and toddlers and children, they have 1 to 2 stools. So there is no normal number for the bowel motion per day for each children. Now, if we go to the definition of diarrhea, they have, or it has more than one definition. We can call this definition, the first one, as a clinical one. And we have what is the scientific or the highly precise definition. So diarrhea, it means the passage of 3 or more loose or liquid stool. It may be loose or it may be liquid per day. Or we can say it is more frequent passage than is normal for that individual. So if a child, his age is 5 months or 4 months, and his normal bowel motion in normal circumstances, it is 5 per day. This is normal. But when he has more than 5, 6, or 7, this is regarded, and it is loose stool or liquid, it is meaning this baby has diarrhea. But in general, because in older infant and children, it is 1 to 2 normal. So if it is more than 3, and it should be of loose consistency or liquid, so regard this as diarrhea. So diarrhea, it is an increase in the frequency more than the normal, and it should be associated with increase in the fluidity or decrease in the consistency of the bowel motion. But in diarrhea, and from this we will know the scientific or the highly precise, how we define diarrhea scientifically. We have to know that the water content in the stool is more than 10 mol per kg per day in infants and young child. So if the weight of a stool is more than 10 grams per kg per day, or it is more than 200 grams per day in teenager and adult, this is meaning diarrhea. So from this definition, we know that we should weigh the bowel motion to check its volume and to check its weight. So if it is more than the normal, it's regarded as diarrhea. This is the highly precise scientific diarrhea. It is by weighing the bowel motion. So these are 3 facts. That is, frequent passing of formed stool is not diarrhea. So look at this. It should be increase in the frequency plus increase in the fluidity or loose or liquid stool. Frequent passing of formed stool is not diarrhea. The second fact is passing of loose or pasty, like the toothpaste stool, by breastfed babies is not diarrhea. So that's why it's important to ask in the history about the type of feeding of this baby. If he is breastfeeding, So the pasty stool, loose stool, it is not regarded as diarrhea. And the third fact that diarrhea is not a disease per se, but it is a symptom of number of illnesses. So that's why we say diarrheal disease, not a diarrhea as a disease. It may be a symptom of disease other than it. What are the epidemiologies of the diarrhea? Of course, when we talk about the diarrhea, we talk about the most common disease or problem we are facing in a practice in pediatrics, here and everywhere. So, diarrhea is a very common problem in children less than 5 years, as we said, and it is the second leading cause of death in children less than 5 years, and 50% of them are chronic diarrheal illnesses. And we will know what is the difference between chronic and acute. Diarrhea each year can kill about 700,000 baby or child all over the world. Now, what is the pathophysiology? That's meaning what makes the normal stool and its consistency and its content changed? Why? We have a different mechanism to develop diarrhea. The first mechanism, it is called the osmotic diarrhea. And the osmotic diarrhea, it is result from the presence of non-absorbable solutes in the GI tract. These non-absorbable solutes, it will causing the pulling the water from the inside the lumen of the GIT and causing the osmotic diarrhea. The example for this is the lactase deficiency and the lactose intolerance. And here, if the baby is fasting, stop taking the feeding for 2 to 3 days, the diarrhea will stop because it is presence of non-absorbable solutes. The second mechanism is the secretory diarrhea, and here results from substances found inside the GIT lumen. It could be bacterial toxin, and the example is like the Vibrio cholera, and this will increase the secretion of chloride ion and water into the intestinal lumen, and here the fasting, it will not affect the outcome of the diarrhea because the toxin found, like in cholera, like in a Clostridium difficile toxin, it will. This is the primary cause for the secretions of the chloride ion and water. The third mechanism is the inflammatory, where there is conditions that there is an inflammation and ulceration of the intestinal mucosa, like inflammatory bowel disease. So we mean the Crohn's disease and the ulcerative colitis. And this will lead to pouring of or release of the plasma, of protein, and sometimes the blood. So that's why it's bloody diarrhea, and the mucus with fecal bulk. The fourth mechanism, it is the malabsorption. Malabsorption, it means result from the osmotic or secretory. It may be both or it may be one of them. When there is a loss of surface area or a part of the surface area, it is lost in the bowel, like villus atrophy. Such conditions like pancreatic insufficiency or short bowel syndrome, or that here there is decreased absorption of the nutrients, so lead to malabsorption. The example also is celiac disease. There is villus atrophy, so there is no absorption of the nutrient. The fifth mechanism is the motility disorder. Motility disorder, it may be hypermotility or hypomotility. So we can find it like in the irritable bowel syndrome, in toddler diarrhea, and or we can call it the chronic non-specific diarrhea. These are the different mechanisms. And we can see it from this slide. Here is the normal, where is the food, or nutrient, and the fluid, it should be absorbed from the intestinal lumen. While in osmotic diarrhea, as I said, the presence of non-absorbable solute, it will lead to release of the water with it. It will pull the water. So this is called why called osmotic. osmosis of the water from the GIT. Secretory, as I said, it's mean presence of the toxin of bacteria inside the GIT, so it will lead to secretion of chloride ion and water. When we say inflammatory, so you can see here by inflammation of the intestinal mucosa, presence of ulceration, so it will lead to, as we said, the pouring of the plasma, blood, and protein in the mucus, and the motility, it affect by either increase or decrease the motility of the GIT. Now we will go directly to the acute diarrhea. And what is acute diarrhea? Now we know the definition of diarrhea in general. And when we say acute diarrhea, so it is linked by certain period of time. So it is the abrupt onset of a 3 or more loose. Look at this. We go back to the definition, the clinical, which is presence of a 3 or more loose. 3 or more loose. It should be loose. If it is not loose, well formed, it's not diarrhea. So here it is abrupt onset of a 3 or more loose stool per day and lasts no longer than 14 days. So it should be within 14 days. If it is persist to 14 days or more, it is not acute diarrhea. The etiology of acute diarrhea, we have 4 main causes. These are 4 main causes, we should know it. Firstly is the gastroenteritis. And the gastroenteritis, it may be of many causes, many causative agents for gastroenteritis. The second is antibiotic use. The use of antibiotic also may induce diarrhea. The third is the food allergies, and fourth is food poisoning. So these are the causes of the four main causes of acute diarrhea. This is not just in pediatrics, even in adults. So if we come to that gastroenteritis, the gastroenteritis may be caused by viruses. It's mainly by viruses, more than the bacterial pathogens or parasites. And the most common virus is the rotavirus, or astrovirus, calcivirus, or enteric adenovirus. Bacteria can cause gastroenteritis, yes, like the Campylobacter species, the Clostridium difficile, E. coli, Salmonella, Shigella, and Yersinia. Parasite, yes, the Giardia lamblia, Amoeba histolytica, and the Cryptosporidium parvo. And these are the causes of the what we can call the infective diarrhea, because it is due to gastroenteritis. While the antibiotic-induced diarrhea, this is meaning that taking of antibiotics or a broad spectrum or multiple antibiotics taken before a time of diarrhea. It may be extended to 1 month. It may be before taking the development of diarrhea, taking the antibiotics before 1 month. So here is, we can know it by the relation between development of diarrhea and taking these antibiotics. And we have what's called, as we said, the food allergy or food poisoning. This is maybe associated with, if it is the allergy, it is associated with the presence of signs like the allergy, urticaria, or rash, or swelling, or abdominal pain, and development of diarrhea. And the poisoning, usually the poisoning, this is common problem. It may be associated with nausea, vomiting, abdominal pain, and it may happen after ingestion of some contaminated food. Now, what are the signs and symptoms of acute diarrhea? Of course, the acute diarrhea may be watery. It's very loose to be watery, and sometimes it may contain blood or mucus. Stool may float, which may indicate there is an increased fat present in the stool. This is called the steatorrhea, presence of fat. So acute diarrhea, this is the characters. I mean, these are the characters of the stool itself. The acute diarrhea may also be accompanied by the GI manifestations, like the urgency with bowel motion, and this is very clear, abdominal pain and or vomiting, or bloating, rectal pain, nausea and vomiting, and weight loss and fever. Weight loss because of the dehydration. If it causes severe dehydration, so the weight loss is significant. Especially we are talking about infants, and especially in young infants. So what is the most threat or most severe threat for the diarrhea? It is the dehydration. So why we are always taking the diarrhea seriously, although it is simple, although it may be self-limited, because of the risk of development of dehydration. And you know all the details about the types, the causes of the dehydration, and about the presentation. So how we evaluate the patient with acute diarrhea? What we know to evaluate? Clinically, we have the history. So in history, we have to focus on the history of present illness. And we should cover all the questions about diarrhea, about its quality, about its frequency, the duration of the stool, the consistency, about the presence of other GI manifestations. And we should also about if there is a history of taking antibiotics within even not just 1 month, even in the previous 2 months, because this is maybe due to antibiotic in use. Also, it is very important to ask about the element of dyes. If we think this is because of some certain foods, we had to ask about the history of the constipation. Sometimes diarrhea comes after constipation, called the soiling. And it is important to assess the risk factor, like if there is recent travel. Recent travel is very important if we travel to endemic area, or changing the food habits, or ingestion of contaminated food. This is very important. And also we should check on the review of systems, because in the review of systems, we will know if the diarrhea could cause or affect the generally on the body by development of the dehydration. Then, of course, it is very important to perform physical examination. In physical examination, the vital signs very important, like checking the tachycardia, the heart rate, and the temperature and the blood pressure. These are very important because they are the signs of hypovolemia. And the general assessment about the presence of lethargy or general condition of the baby. You know these informations from the physical examination, because we are talking about diarrhea. So we are concerning if there is dehydration or not. So we have what's called the red flags. Presence of the red flag signs, it is making the condition serious more than the other. Like if there is tachycardia, there is hypotension, and lethargy, because these are signs of significant or severe dehydration. If the baby has bloody stool, if there is bilious vomiting, because bilious vomiting indicates if there is intestinal obstruction or there is a paralytic ileus causing a functional intestinal obstruction. If there is extreme abdominal tenderness and or distension, also these are red flag signs. And finally, if there is petechiae and or pallor, because the presence of these may indicate the development of complication, like what's called the hemolytic uremic syndrome, when there is a thrombocytopenia and there is affection of the renal failure, acute kidney disease may develop. So all these are red flag signs. This table and the other will show the questions we should ask about, and in examination what we should look at and what we should feel. Then we will decide which plan of management we will depend according to the level of the dehydration. So this lecture is very important to be linked with the lecture of the dehydration and the fluid therapy, because in dehydration and the fluid therapy we talk about the dehydration itself, and we said at that time the main cause is the GI loss. So when we say GI loss, we mean the diarrhea. So it's better to link it with the information there. But here we will focus on the diarrhea as a cause, about the presentation or the complication like the dehydration, what we have do there. So the diagnosis first is by clinical evaluation. The clinical evaluation by history and examination is very important to diagnose. Investigation, yes. We need to do some investigations, like what? Of course, general stool examination. This is very important because the presence of a general stool examination, the presence of the pus cell indicate what? And the presence of the acidity or change acidity of the stool, presence of reducing substance, we call the pus cell or the fecal leukocyte, presence of parasite. All these are important to diagnose the cause of the gastroenteritis. Stool culture may be made, and this is when we are suspecting the cause bacterial. So for the Salmonella species, for Shigella, for Campylobacter jejuni, and there is signs of the colitis or a fecal leukocyte are present. This is meaning the cause is bacterial, not viral. So we have what's called the enzyme immune linked assay for the rotavirus or adenovirus if we think the cause is a viral diarrhea. And we have the latex agglutination assay for the rotavirus. And of course, we should follow the renal function and the serum electrolyte. Why? Because this is affected if there is a degree of dehydration. We said the dehydration is the most severe threat. So we should follow the renal function and the serum electrolyte because it should change respectively. Now, from the, can we differentiate between the small bowel and large bowel diarrhea clinically and by lab investigation? Yes, we can differentiate. According to these parameters, so according to the volume, the small bowel diarrhea cause large volume or called voluminous, while the large bowel diarrhea, and we can call it colitis, it cause small volume. According to the color, it's always light color. يعني لذلك تسمعون الcolor of the stool, it may be a greenish or yellowish in the small bowel diarrhea, while in large bowel in colitis it is dark. The smell is also can be differentiating. It is very foul in small bowel diarrhea. The nature of the diarrhea, it may be soupy and greasy in the small bowel, and it may be mucinous or containing mucus or like a jelly in the large bowel diarrhea. The type, the consistency, it is watery, mainly goes with the small bowel diarrhea, while the large bowel diarrhea, it is mucoid. Presence of blood in a stool, it is rare in small bowel, while it is common in the large bowel diarrhea or in colitis. And the presence of fecal leukocyte, it is rare in small bowel diarrhea, and it is common in the large. So we can differentiate clinically and by lab investigation between the site of the gastroenteritis or the site of diarrhea, if it's small bowel or large, from these characters or from these parameters. Now, how we manage acute diarrhea? Of course, acute diarrhea, as we said, it is self-limited usually, whatever the cause. But sometimes it needs to be managed. So we have what's called the protracted courses. Protracted courses here, it may be prolonged, but when it becomes prolonged, it is not more than 14 days. Because if we pass the threshold of the 14 days, we are out of the acute diarrhea. So the management is generally supportive. Specific management usually is not essential. Supportive, it's by meaning prevent the dehydration or treatment of the dehydration. So the best option here is the early use of the oral rehydration therapy. And we talk in details about it. It may lower the mortality rate by as much as 93% after introduction of the ORS and the treatment of diarrhea. The mortality rate because of it decreased by 93%. In this table, we can see the content or the constituents of the oral rehydration solution. We have what's called the low osmolality, and which is the new version that start to act since 2003, and the old version. Here is you can look at the osmolality. It was a 311, now it is reduced to 245. And why they reduced the osmolality? Because this decreased the stool volume and decreased the need to going for the IV fluid. It's mean failure of ORS. In this side of the table, we can know the constituents and the weight of the constituents. And all these elements, it should be dissolved in 1 liter of water and given in frequent sips. This is the traditional, the classical, the formal form of the ORS that is authorized by the UNICEF and by WHO. And you can see here the constituents of this medication. Nutrition and diet is very important. We should make changes in the daily nutrition and diet of baby during diarrhea. So, combination of complex carbohydrates, it's very important, like the rice, wheat, potatoes, bread, lean meat, yogurt, and fruit and vegetables. So that's why we give them the rice water for those patients with diarrhea. So, but these elements, we should eliminate it, or we should reduce it during the time of diarrhea. High-fat food also should be avoided. The soft drink, like the juice or sport drink, these should be avoided. This is regarded as a hypotonic fluid or a clear liquid fluid, and this will lead to electrolyte disturbances. But if the baby is on a breastfeeding, it should not be interrupted. It should not be interrupted. We should continue on the breastfeeding. And the food which is high in carbohydrate are recommended to enhance the fluid and sodium absorption. You know what is called the co-transportation of the carbohydrate with the sodium. That's why the ORS contains sugar and contains sodium chloride. So the co-transportation will enhance the absorption of the fluid and the sodium from the GIT, preventing the dehydration. And we have what's called the starving. Sometimes families try to prevent the feeding of the baby at all, but this is very difficult because this may lead to villus atrophy and will lead to increase the course of diarrhea or making it even chronic diarrhea. So the feeding is recommended. It is no need to stop the feeding, just to change the pattern of the type of feeding. We said the giving only clear liquid for several days can prolong the diarrhea, or what's called the starvation stool. Zinc is very important to give zinc supplementation because this is reducing the duration of diarrheal episode by 25%. You know the effect of the zinc supplementation and enhancing the immune state of the person, of the patient, not just in diarrhea and pneumonia now and COVID-19 they give it. So it is also associated with a 30% reduction in stool volume. That's why we give it. Now, and it will decrease also the need for the admission to the hospital and even overall the mortality. If the baby is less than 6 months of age, so we give him 10 milligram per day in 10 to 14 days. If it's more than 6 months, we give him 20 milligram. This is according to the recommendations of the WHO. We have what's called the probiotics. What is the probiotics? We may give it during acute diarrhea. They are healthy bacteria, may reduce the duration of diarrhea by about 12 to 13 hours. It should be given at the beginning of the diarrhea. they found as sachet could be diluted with water and taking at the beginning of the acute diarrhea. We have the recommendations about the medication that may slow the intestinal motility. يسموها المother's القابضة. There is no قابضة. There is no قابضة contraction, constriction. There is no meaning of قابضة in acute diarrhea. There is no need to stop the diarrhea. What you should do is to manage the manifestations according to the presence of diarrhea, to prevent the dehydration or to manage or treat the dehydration. So what we give the slow intestinal motility, this will lead to allow to overgrowth of organism. So that's why it should be avoided. Imodium or imodium and diphenoxylate with atropine, this may cause ileus, bloating, respiratory depression, and drowsiness. So it is contraindicated in babies up to 10 years of age. اللي نقصدها هي من اللوموتيل, vacontil, الانتيروستوب. All these are the trade name of the diphenoxylate with atropine. May cause respiratory depression and drowsiness. So there is no, should be avoided. Antimicrobial use, very important in diarrhea if we diagnose it as infective causes. So according to the infective cause, these are groups of antibiotics or even antiparasitic given according to the specific cause that is gained by either the strong or positive clinical features or by doing stool culture. While other than this, the antibiotics or the antimicrobial is not part or essential part of a treatment of acute diarrhea. Now we will talk about specifically the most common cause of the viral of the gastroenteritis, which is the most common cause of gastroenteritis, which is the most common cause of acute diarrhea. So we are talking about the rotavirus. It is the most common cause, as I said, of viral gastroenteritis. And the most common cause of gastroenteritis is viral. And the most common cause of diarrhea is gastroenteritis. So that's why we talk specifically about the rotavirus. It is a double-stranded RNA virus with serotypes. It affects the small intestine, so it's causing a small bowel diarrhea. That's why it's causing voluminous and watery diarrhea without leukocyte or without blood. It may affect the infants from 3 to 15 months of age, and its peak incidence during winter, not during summer. And the route of transmission, of course, it is the fecal-oral route, and its incubation period is 1 to 3. What are the signs of symptoms? Like any acute diarrhea. So there is vomiting in most of the cases, low-grade fever, watery, very loose diarrhea within 24 hours, and it may last several days. So the mother comes to you and she needs to stop the diarrhea at the same day of visit. But this is not a clinical and it's not a scientific way, because you have to tell her it will take 4 to 8 days, and it may be longer, of course, and even compromise patients. And your aim in management is to prevent or manage the dehydration that may happen due to the rotavirus infection. The diagnosis, of course, by clinical evaluation. You may do the rotavirus antigen in stool, the enzyme immune linked or the latex agglutination test, and electron microscopy. It may show the presence of the virus. Of course, the treatment is non-specific and supportive. And of course, the most important is to take the ORS. And of course, the use of lactose-free diet may be associated with shorter period of diarrhea, but it is not essential. Not all diarrhea, acute diarrhea due to rotavirus, you should stop taking the usual formula taken by the baby. If he is breastfeeding, you should keep him on breastfeeding without changing. And of course, you should reduce the fat intake during the recovery, because a malabsorption of fat can happen because of acute diarrhea. And sometimes there is a specific antiviral antigen useful in limitation the duration of the disease in immune compromised patient. Prevention, we can prevent the rotavirus infection, yes, by giving the, of course, by the good hygiene, of course, and prevention of fecal oral contamination. And second is by giving the vaccination. Since 2007, the American Academy of Pediatrics issued the bovine-based pentavalent vaccine that is given in 3 shots in 2, 4, and 6 months. And this is in our country as part of the expanded program of immunization. We should give the babies at this period of age the rotavirus vaccine and decrease the likelihood of development of the diarrhea. Now we go to the chronic diarrhea. Now we are finishing the acute diarrhea and we're going to the chronic diarrhea. So we said the diarrhea, it may be acute or chronic according to the duration. So chronic diarrhea, it means decrease of consistency and or increase of a frequency and or volume of stool lasting for more than 2 weeks. The cut time between the acute and the chronic diarrhea, it is the 2-week duration or 14 days. So in the acute diarrhea, it was 3 or more liquid or loose or watery diarrhea. Here is decrease of consistency and or increase of frequency. Actually, in chronic diarrhea, the change in the stool consistency is more important than the stool frequency. So we focus on the consistency if we are talking or dealing with the chronic diarrhea more than the frequency, even if the frequency it is of little, 3 times. But what is important, it is the consistency, if it is decreasing, or the volume of the stool. So you remember the volume of the stool, it is more than 10 grams per kg per day in infants and toddler, and more than 200 grams per day in older children. If we can weigh the stool per day or per time, and we can see it more than these normal values, so we regard it as diarrhea. Because the duration more than 2 weeks, so it is regarded as chronic diarrhea. We have a definition, or we have a term called persistent diarrhea. So what is persistent diarrhea? Here, the diarrhea that may last more than 14 days. So why we don't say this is a chronic diarrhea if it is more than 14 days? Because it implies a more abrupt onset if it's compared with a chronic diarrhea. More abrupt onset, it means it is acute in its onset, in its origin. But because it is more than 14 days, we call it persistent diarrhea. While the chronic diarrhea, usually it is started to be insidious. And the main important point is the consistency of the stool and the duration, while in persistent, more abrupt onset, like what happened in acute diarrhea. Now, what are the causes of a chronic diarrhea? It's better to classify the chronic diarrhea according to causes to 2 main groups. The first, we call it that is without failure to thrive. That's mean group of chronic diarrhea that didn't cause failure to thrive, like chronic non-specific diarrhea. We will talk in details about this. Infectious colitis. Infectious colitis also, it didn't cause failure to thrive. Lactose malabsorption, lactose intolerance. Small bowel bacterial overgrowth. All details about this found in the lecture in a table, a specific table talking about the clinical features of these causes and how we diagnose it by the major lab finding. Irritable bowel syndrome also didn't cause failure to thrive. While the group that caused failure to thrive, affecting on the growth of the baby, it may be intractable diarrhea of infancy. And here, a high risk of malnourished or immune compromised patient and need to be for the support with the nutrients. It's called intractable diarrhea of infancy. Allergic enteropathy, like the cow milk protein allergy. This is called allergic. Of course, this will cause failure to thrive. Celiac disease. In the next lecture, we will talk about the celiac disease in details. Inflammatory bowel disease, Crohn's or ulcerative colitis. Of course, it will cause failure to thrive. Immune deficiency. Of course, they are failing to thrive. Autoimmune enteropathy, the same. And the neuroendocrine tumors. This is by the presence of what's called the vasoactive intestinal peptide secreting tumors inside the intestine, and of course associated with failure to thrive. Cystic fibrosis, also we will talk about it in details in further lecture. Now, how we evaluate the patient with a chronic diarrhea? Of course, we have the cornerstone, which is the history. In history, it is important to focus on the stool characters about its frequency, the volume, and appearance. Presence of a blood or mucus, because it may indicate the inflammatory cause or nature. Relationship to feeding or dietary intake, like if we talk about the lactose intolerance or about the allergic enteropathy. Presence of gastrointestinal symptoms like abdominal pain, weight loss. We talk about the failure to thrive, so there is weight loss, not because of dehydration. This is not an acute weight loss because of dehydration. Weight loss because there is failure to gaining weight, or failure to thrive, or even weight loss. Presence of rash, if we talk about the allergic enteropathy, fatigue, vomiting, joint ache, oral ulcer, or among other extraintestinal manifestations. These are very important. The recent travel, very important if there is a history of recent travel or exposure to new water source, family history, and sick contact. Very important in the history. Now, the physical examination, of course, here we will assess both the hydration state or the presence of dehydration and the growth parameter, the height or the length, the weight, and the OFC. Because we are talking about the chronic diarrhea, and we should know, we should classify from the physical examination. This is causing failure to thrive or they didn't cause failure to thrive. So not just the dehydration is very important because we are talking about a chronic problem. Signs of a nutrient deficiency, because it is a chronic, there will be vitamin deficiency. The most important is the zinc deficiency, causing the perianal dermatitis and leg deformity, like bowing of the leg, and the vitamin deficiency of vitamin D, of course. Presence of abdominal distension may be a sign of malabsorption or small bacterial overgrowth, and sometimes may be tender, like an inflammatory and ulcerative colitis or Crohn's disease. The rectal examination, very important, because sometimes it may reveal the nature, like the inflammatory bowel disease, or there will be a loss of some surrounding subcutaneous tissue. This means signs of failure to thrive or losing weight. We can see it, or malnutrition and celiac disease. So these are very important points to check in the physical examination. If we go to investigations, of course, the stool test, it will be primary. Stool culture, because it may be a bacteria, and going from acute to a chronic. A Clostridium difficile toxins, antigen detection, if we talk about the Giardia may cause chronic diarrhea, or Cryptosporidium parvovirus. And the stool electrolyte and osmolality. This is very important to differentiate in a chronic diarrhea if this diarrhea is osmotic or secretory. So how we can differentiate? This is by calculation or measuring the osmotic gap. How we can measure the osmotic gap? We should know the stool osmolality minus 2 multiplied by stool sodium and the stool potassium. So normally the stool osmolality is about 290. And the presence of the stool inside it about sodium 30 millimole. So that's why we give the 30 millimole of sodium bicarb if we are need to replace the ongoing loss of the diarrhea and the management of dehydration. You should remember this. and the stool potassium, which is about 75 millimole per liter. This is the normal values for the normal stool. So after calculation or measuring the osmotic gap, the net result, if the osmotic gap is more than 125, so this is a pure osmotic diarrhea. If it is between 50 and 250, this is a mixed, or what's called the mild carbohydrate malabsorption. But if it is less than 50, so this is a pure secretory diarrhea. This means there is secretion of the chloride ion. The example for the pure secretory diarrhea, it is the Vibrio cholera. The example for the pure osmotic diarrhea is the lactose intolerance. And sometimes we have mixed or mild cases of carbohydrate malabsorption when the osmotic gap, it is between the secretory and between the osmotic. Again, in the stool examination, the presence of fecal white BC very important, and reducing substance also may reveal the carbohydrate. Presence of reducing substance mean the organic acid, which is the carbohydrate, it is not absorbed, so it will be present in the stool. It's called as reducing substance. Measurement of the fecal fat is very important because it's a presence. It means the precise detection of steatorrhea. Now, just to remind you what happened in the osmotic diarrhea and in the secretory diarrhea. Here, presence of non-absorbable solute, it will pull out the fluid, and can happen in the large bowel more than the small bowel. While here, the presence of toxin, it will lead to secretion of the chloride ion and water. We can differentiate between the secretory diarrhea and osmotic diarrhea by clinical evaluation and by the lab investigations or by lab results. This table is very important. You should keep it. You will be asked about it. What is the criteria of osmotic diarrhea and what is the criteria of secretory diarrhea according to these parameters? Blood test, important to do it because we are talking about chronic problems. So it may cause anemia, it may cause thrombocytosis, it may cause a vitamin deficiency, white BC count and differential count, very important, a high ESR or positive. Selective protein support the inflammatory markers, of course. If we found the elevated tissue transglutaminase antibody, this is important in celiac disease. We will talk in the next lecture. Serum albumin, important if there is hypoalbuminemia, and fat-soluble vitamins also will be affected because there is a fat malabsorption. And the additional test we should do is the CT scan or MRI and the inflammatory bowel disease to see the extent of the disease that affects the thickening of the bowel. And we may do the breath hydrogen test and carbohydrate. We will talk about this in further lecture. And endoscopy, of course, for the specific or the confirmatory diagnosis of celiac disease or the inflammatory bowel disease. Now we will talk in just a few words about example. So I didn't talk about the management or treatment of the chronic diarrhea because it is according to the underlying cause, according to the nature. And in the further lectures, we will talk about the malabsorption and about the types or forms of chronic diarrhea. So we will talk about the management accordingly and specifically next. Now, talk about the chronic non-specific diarrhea or what's called the toddler diarrhea. This is the most common cause of chronic diarrhea, loose stool, and otherwise thriving children. They are coming to us in a practice complaining of chronic diarrhea by the duration and by the consistency of the stool and even by the frequency. But the baby is thriving well, normal baby. So what are the causes of this? Is called toddler diarrhea at the age between 1 to 3 years. It's more common, or called chronic non-specific. Maybe abnormalities of bile acid absorption in the terminal ileum may cause it, or excessive intake of osmotically active carbohydrate. They take juice or fruits in general. It may cause the the hypermotility or the loose stool, or abnormal motor function. It may be a problem related to the motor function of the GIT. Now, the clinical features, the baby is thriving, well, normally, healthy, but, and his age, of course, it's between 6 and 20 months, so that's why we say it is a toddler diarrhea. They have frequent loose bowel motion, more than 3 to 6 per day, and especially during waking hour. But at night, there is no diarrhea, because at waking hour, he ingests something may induce the diarrhea, like the fruit and juice, but during the sleeping, there is no ingestion, so there is no bowel motion. No blood in the stool, because it is simple and normal growth, as we said, and there may be a possible family history of functional bowel disease. And the investigations, it need no investigation, but if we do the investigations, all will be normal, negative. The course of the disease, it may worsen with low residue or low fat or high carbohydrate diet during period of stress and infection. Taking the low fat or the low residue and going on concentrating on the juice, on the fruit, it will increase it. As we said, excessive fruit juice ingestion worsens the symptoms, and it is spontaneously resolved usually by the age of 3.5 years or after potty training. Potty training, that when the baby can independently go to the toilet and do the training by himself. Now, the management, it's not need for the specific management just to change the dietary fibers. So what increase the motility, we should eliminate or avoid it. A slight increase in dietary fat, we should increase the fat, we should restrict increase in the fat. Also, it is very important for the normal brain growth and development. And we should restrict the osmotically active, like the fruit juice, as I said. It will help control the symptoms. And here, in those patients, we can use something to affect on the motility of the diarrhea for symptomatic relief. So we use the lobromide. Thank you. I finished my lecture. Thank you for listening. If you have